I'd like to welcome Senator Warner with us today. This is not his first meeting at the Front Royal. Senator Warner knows our community quite well, has been very involved with the opioid issue and keeping in touch with that. He also was very helpful for us. His office was very helpful for us when we tried to work with the FDA. Unfortunately, the FDA did not want to change their minds on their ruling, but Katie was, your staff was very helpful in helping us try to address issues there. I'd like to go around the room. We have trustees, we have some physicians, we have members of the management team. So if you quickly go around the room, introduce yourselves. So if you want to, this is soon going to be a vacant hospital. And we think it would be great for a federal office building.
Have you got what agency picked out already?
Here you go. It's not you. We're flexible, but actually, you may know. I'm sure you're aware. We are building a replacement hospital on the ground. It's a $100 million project. It's been something that we have been planning for over 15 years, and the board, to their credit, has decided it was time to do this. So it will be the sixth hospital that we built. So we had totally recapitalized our healthcare system. We have 4 critical access hospitals. We have Winchester and Warren. And when the new Warren opens, we basically will have recapitalized our entire healthcare system. And we serve an underserved community, as you know, high percentage of Medicare and Medicaid and uninsured in a very rural area. But we are financially strong, and we have appreciated the relationship we have with your office. We were happy about Medicaid expansion that has helped our community immensely. So we have a number of topics I'd like to discuss, but first we'll go and introduce ourselves. Dr. Wynn.
Hi, Buddy Wynn. I'm North Big Sur.
I'm Travis, President of Page and Shenandoah Memorial Hospitals. It's 2 of our 4 critical access hospitals.
Yeah, we had.
You helped us a lot.
That was like, how many years ago was that?
Yes.
Yeah, it was.
That was like a holy heck kind of moment. Yeah, that was like we were really close to.
We were close.
The critical access designation.
Yeah.
It was 2016.
Yeah.
16 or 17.
It's been longer than, but it's your office and Senator King's office was very helpful to ensure that we stay. So thank you again.
Thank you for what you do.
Hey, Senator Administrator, Virginia Hospital Association.
Hi, Tom Gilpin, local business manager from Clark County, Valley Health Board member.
Yes, sir.
Across the Valley Health Board, and I'm also the president of the Northern Shenandoah Valley Substance Abuse Coalition.
Nick Restrepo, Vice President Medical Affairs at Winchester, and I'm a board member of Mr. Kluss's Coalition Board.
Excellent.
Good morning, I'm Harry Smith, trustee of Valley Health, chair of the Finance Committee. I'm also a member of the RPB Region 3 with the American Hospital Association, and I'm a career banker.
And in a community bank.
Yes.
Who passed 2155?
Yes, sir.
Thank you.
Thank you. Thank you.
Good morning, Philip Graybill, VP of Finance for the Southern Region of Valley Health. That's 3 rural hospitals.
Good morning, I'm Dr. Ray Grimm. I'm the token veterinarian on the ground. I'm Floyd Heater. I'm president at Warren Memorial Hospital, and I oversee the Southern Region market for Valley Health System.
John Lazinski, board member, Valley Health trustee, resident of Rappahannock County.
Bob Melvin, I'm a small community general surgeon.
Good to see you, Senator.
I'm Pete Gallagher, I'm the Chief Financial Officer for Valley Health.
I'm Ian Savon, I'm the chief physician executive for Valley Health, and you arrived from Maine.
And I do want to explain, I would normally have on a white shirt today, but today is you wear red for Women's Heart Health. So I work with them.
I'm the only one.
All right, bad staff work.
Early St. Patrick's Day.
So a lot of our employees wear red, and we have a lot of women in our organization. So Women's Heart Health is something that's near and dear to our organization.
Well, should I?
Sure. So,
Well, thank you all for being here. Thank you for letting me come back around. I want to particularly thank Mark, who I've known now for more than a decade. I cannot believe you're letting him, move on at the end of the year. But I've always appreciated the relationship I've had with Valley Health. I remember some of the earlier sessions when we tried to drill into some of the issues around substance abuse. I want to go through this agenda. Obviously, echoing what Mark already said, I think it was very appropriate for Virginia to expand Medicaid. I wish we would have done it earlier. I've actually got legislation in place that is broadly bipartisan that would say those states that were slow to the draw, we should not lose in terms of the longer term higher level match. Whether that gets through or not remains to be seen. I'm obviously very, very concerned about the court case and what it would do. Why in the heck, where I work, we can't say, okay, whether we call it ACA or Obamacare, let's keep what was good about it, let's fix what was wrong. I can guarantee you, I'm sure everybody here has got a dozen different areas. I can give you a dozen different areas where ACA did not get it right, but the idea that we're going to flush all this, we've gone through the growing pains, it's not working perfectly, but we ought to be into fix mode rather than simply replace mode. Love to hear your comments on that. One of the areas that I've been very active on as well it has been telehealth, and we've been very active in seeing how we can get greater reimbursement levels because in underserved communities, I think telehealth is still an issue that offers a lot of opportunity, and frankly, it's not the technology that's holding us back at this point. I really do think it is, it's CMS and some of the reimbursement rates. Want to hear from you on that issue. I know there's some concerns as well about the, how do I say this with press in the room that's appropriate. I think a number of states, including Virginia, we've been creative on how we do our financing, on some of the provider taxes and how that helps move our match rate. I do wish we could kind of have a clean sheet where we could end up thinking about a financing system that as a guy that's been a business guy longer than a politician, that would still pass more kind of straight accounting muster rather than the tools we got. But if we come in and yank away the system that we've got right now, for systems like yours, it would be devastating. Two other issues I want to just briefly mention, because I really want us to go through this agenda in great detail. I want to talk about the surprise billing issue. My family's experienced it. And I know that the one version of the bill that's out there that would really put providers at a very great disadvantage, I don't support. I also, to be fully transparent, and I said this as somebody who used to be a venture capitalist, I'm not all that keen on what some private equity groups have done in terms of coming in and buying up some of these emergency room doc practices and frankly arbitraging the prices. My family got a $190,000 surprise bill from a hospital that my daughter has used repeatedly and for a procedure that frankly we hadn't been covered at earlier times. This is one that we need to get resolved, because otherwise, the anger and frustration around that is gonna rightfully boil over. And then, last, if we've got some time, would love to bring you up to speed on what may happen on some of the drug pricing issues. I mean, I'm on the finance committee. We've taken, I think, a moderate first step, but would love to get feedback from y'all on that, as well as all these things on the agenda here. So that is opening comments. Mark, let's take it away and let's get into the meat of this.
Certainly, I think your thoughts about the ACA, I don't want to speak on behalf of the group, but clearly we think the ACA has been good, and we certainly are advocating for it to be repaired, not replaced, especially when the options that are being in place have not been fully valid. The ACA has had a significant impact on reducing uninsured. It is producing improved health outcomes for populations. If you look at states that had expanded the ACA, expanded Medicaid through the ACA, their hospitals are more stable. The majority of hospitals that have closed in the last decade are in states that have not expanded Medicaid, and I think those hospitals are continuing at risk. We would like to see the ACA strengthened and not abolished. If anyone else would like to comment on that, but clearly has improved health status in Virginia. It's clearly strengthened the hospitals, and particularly rural hospitals. And we saw, Pete, you could comment, over a 50% reduction in our self-pay in this year.
Uncompensated care. Significantly now, but bad debt and self-pay, so it's been
And people are accessing the healthcare system. They're getting preventative tests, they're getting screenings. The one area that I know Dr. Skrepla can talk about is one area that Medicaid covers, but is not a supply, is addiction treatment opportunities, which is certainly not just affecting our community here, it's affecting many rural areas and urban areas across the country. So Medicaid is going to cover that, but can we find enough providers to render the service is something that we're challenged with. Dick, if you want to say anything about that.
Sure. So actually, this week in Health Affairs, there's an article highlighting Virginia's ARCH program, which was a revision of how Virginia Medicaid compensates for addiction care, and it demonstrates the value of investing up front, and by expanding treatment prior to the crisis, there's a significant decrease in emergency room utilization by that population compared to the prior model that we had in place in Virginia. So just the benefit of ARTS and what has been done over the past few years, Secretary Hazel, when he was in that position, kind of advocated and got that in place. And now you're seeing significant long-term benefits to the population and in turn to the overall system of care.
And is a lot of this going into just, making sure that patients get to appointments and other wraparound services, or talk to me a little bit more?
That's not as robust as one would like. So the initial emphasis of the program for Virginia Medicaid has been to create a reimbursement structure that makes it feasible to be able to have treatment programs outside of hospital settings for people with substance use disorder. You kind of hit the big problem we have as a community and as a society is all the social determinants of health. So you have to have those appointments in a place where they're able to get to it. Locally, we've had some movement in that way, but not necessarily the kind of movement that is long-term sustainable or actually enough. And for instance, in Winchester, the Community Services Board moved their treatment program to a bus line. So we have very limited public transportation, but at least the treatment program is at a bus stop, and so individuals are able to get there. The broader issue around housing and safe and sober housing, transportation, food security, all of that continues with basically local efforts. I don't know of a coordinated statewide effort to address those things. There's been some federal government initiatives around rural areas and funding for housing grants, but those are somewhat restricted. And the other thing is they end up in places where you don't have that access to then get into treatment. Steve and I have been working a lot on some of these issues. I don't know if you had any other thoughts in addition.
Well, one of the things I hope we will do, and I think we need to get ready for this to kind of lobby policymakers, is that I think we are beginning to get our arms around the opioid issue, since the level of physicians writing bad scripts and stuff is going down. And my fear is that opioids per se has gotten Congress's attention and dollars, but if we see a decline on opioids and we see an increase in heroin or fentanyl or meth or whatever, that we realize that simply getting an arm around opioid may not deal with all of substance abuse. So the more I think we can talk about this as a substance abuse area rather than simply opioid alone is at least my sense.
Absolutely. So two things. We are at your fear, and I'll come back to that in a second. So that we're in that locally and regionally and nationally. We're at the state where that's an issue. Our local experience was exactly the same sort of approach you had. When we first formed as a local organization, Valley Health, along with municipalities, got together. It was a heroin task force, and we realized at first this issue goes well beyond heroin, and it's all substance abuse. We actually had some fatalities from completely legal substances just inappropriately misused, and so we've had a broader, consistent approach to it locally. As you mentioned, a lot of the funding is very tied to opioids, a lot of the measures for grant dollars and all is tied to opioids, and the need is really much broader. It's just use disorder as well as misuse of substances. You look at emerging trends and the height of data and the data of seizures in our region and the data of issues that we're seeing within the health system. We have a stimulant drug crisis currently, and as you're aware, with the stimulant drugs, you see the increase in violent crime, and that trend here has been, over the past 2 or 3 years, an increasing problem, and there's a perception amongst users when you talk to them and the people in our drug treatment court that the stimulant drugs may be safer, or that there's less of a harsh criminal penalty because they know about the heroin dealer going away for a long time, but the meth dealer doesn't get the same sort of treatment. So there's a whole source of contributing factors. Another emerging crisis is the e-cigarette. So there's a whole new disease, the E-Valley, the e-cigarette vaping lung injury. And we've had patients in our ICU. We had one of the first cases in the state of Virginia with these horrific lung injuries from vaping and vaping illicit substances. And so the whole idea that it's a much broader issue, you're completely correct.
And are we still, because I remember one of the sessions we had a few years back on this topic, the fact the Winchester and all along here, that this is, 81 kind of a transit corridor for the drugs, and we still have that problem? We
do. Fortunately, in the past 3 years, 2 areas, Warren County most recently, and prior to that, Frederick County became part of the Baltimore, Washington, and HIDA. Okay. So the coordination as a result of that, and the resources as a result of that, have been invaluable to the community.
One of the things
you helped us get the HIDA designation for Winchester a couple years ago, so thank you for that.
Thank you for reminding me. Again, I said, tell me. But one of the things that and I've got to call into it. Has Attorney General Herring given any sense of what we're going to do with Virginia's share of the settlement out of the?
Not that I'm aware of. I don't know.
I'm not aware of that.
He may have, but I'm not aware.
One of the things that, and again, this will be, I hesitate to say this concerning where I'm sitting, but
you're safer.
But one of the things what I thought about for a while was, Korean is doing a major expansion, and they're adding a number of new beds, psychiatric and substance abuse beds. We've got the state facility in Salem, and the medical school there in Roanoke really is a lot focused on kind of brain functionality. And I just wondered if, I've been at least thinking, is there potentially a center of, could we create some level of center of excellence? Because I don't think there's been any place in the country that really has kind of put a stake in the ground and, leverage the medical school there in Roanoke, but it would be I would think about it on a statewide basis.
Yes. So there was a meeting a couple of years ago in Charlottesville of all the medical school leadership, so they're kind of at the dean level for that very reason, to see how they could coordinate their efforts, both in the research field as well as the education of physicians, residents, as well as medical students. And they've met a few times. I don't know the exact.
Is anything coming? Well, I just think we're going to get, we're going to reauthorize some more money at the federal level, and we're going to get this one-time slug that's going to come out of the Purdue settlement. I just, I would be very interested if there is a, forward-leaning overall plan on how we leverage that.
So there's a couple things worth looking into more, and I can get you more information around.
We don't need to take the time to,
VCU has gone heavily into this as well, and has some great national resources there that they've recruited, including going and continue. They have a board-certified addiction OBGYN, so they have a lot of significant potential to add to that dialogue. And then the Virginia State Legislature commissioned a study of how we can create a research consortium statewide. That the report went to this legislative session. I was actually on the task force that developed the report, and the idea is to take the research universities and major community healthcare institutions and create a statewide collaborative around research. That would be a great use of that collaborative.
And what I'm simply offering is, I don't know, I gotta talk to Mark about what he was planning on doing, but I think the Attorney General's office has a lot of say over what we do with that slug of dough. And as we deal with, as I deal in the Finance Committee, I have, shall I say, there's no pharma CEO won't take my call. So, you know, I'm not starting to think of the plan, but if there's a really good plan, and, you know, and you say, okay, Warner, can you help find us X, you know, tens or hundreds of millions, that could be a plan that would be brought in statewide, I'd love to be.
So another place, I can get your staff the information, the HEAL grant application for the Commonwealth, the framework's there. We were not a successful state in obtaining that HEAL grant, but what you're describing, the document exists. I can work with your staff later to get that information.
Let's follow.
So Dr. Melver, Dr. Nguyen, you might want to comment in terms of the patient, back to the ACA, the impact you've seen on patients. And, you know, you see what people access themselves service with the Medicaid exchange.
Correct, and personally have had experience with a daughter who, you know, is covered till she's 26 and had some significant anorexic issues, and been there, done that.
Yeah, I got a postgraduate. Mine's 30, and he's been in more treatment centers.
Well, actually, I was telling Mark, it's quite amazing. She went to a place called Acute Denver, which is the only, you know it, okay, Acute Denver, which is the only ICU in the country, and spent, you know, weeks there and then stepped down. And when I went to Acute Denver, they asked me to send them a $125,000 check, which I did, and then our insurance system reimbursed the entire stay. So that was completely amazing. And just the ICU part was $169,000.
She was in that up to 26 age because of her age, right?
Correct. So
normally she
personally, that saved me having to work for Valley Health for another 10 years. Other things I think have been really good. As an orthopedic surgeon, we do terrible things to people. You know, we total knees and total hips and operations that are very, very painful. We used to give them 60 Percocet, you know? And now with e-prescribing, it has really revolutionized the way I prescribe. You know, people leave with 5 or 10 whatevers, and if they need more, all I do is e-prescribe it. And before you had to bring them in and hand them a prescription, you're always afraid that you weren't managing their pain. And as you know, with this whole opioid, we were hammered to death as physicians, gotta control pain, gotta control pain, gotta control pain. And we were the bad guys because we were doing what we were told, and now it's the opposite. So I think that has
Well, don't we need to get to some
There's some happy
equilibrium?
medium.
Because it feels like we were over-prescribing.
Correct.
And then I think
Now we're
docs got under-prescribing.
Now we're under-prescribing because we're all scared up
Yes.
to be that guy. you
Yeah.
know. So, but the e-prescribing I think has really been wonderful. I can be at home and e-prescribe.
That's it. I didn't realize, 'cause I thought there was still, you know, you had to go through the
Well,
physical pickup and all
no,
this other stuff.
it's an app on your phone, and it hooks up to Epic, which is our software system. And I can pull Epic up through Citrix at home, and if somebody needs a prescription, and I only gave them 5% and they're out, if my phone and the computer match, and it e-prescribes it directly to the pharmacy.
And is that, because that's,
That will become state law in July. But it's, I think it's been one of the best things
very good.
from that point of view.
Yeah, no, I think that, you know, certainly on the ACA level, I've seen the changes over time in terms of people getting coverage. But you're talking about the repair work that needs to be done too, and that is that people not being able to get local people on their network on there, and they have to go into Northern Virginia and have to go somewhere else. So there is repair work they right to be done, but it's been essential. We see a lot of people that are coming in that wouldn't have otherwise gotten coverage. And then I see the ones that had to wait, and their disease is more advanced. It could be cancer. So, yeah, it's had a, I agree, a good impact, but repair work needs to be done. As far as the prescribing all that in the opioids, yes, I think there was certainly the overshoot on it, and then there's the reflex undershoot, but I think the good thing is that it's made us all more aware. So I know that I think about it. I ask people, what would you use? Well, maybe we don't need to use that much. And so it's certainly made a consciousness of it among providers much more robust, I would say.
And in our service lines, we've done a lot of work what we call ARAS programs, which are multimodal pain management, periarticular injections, post-op pain management that has everything to do with opioids. And we've actually intercalated that into our order set so that it's not a reflex, it's just there.
Yeah. I'd love to hear more on this because this is something I hear about fall, and I'm not as familiar about on July 1 because I was still thinking of the old systems. Love to hear more.
So Tom or Harry or Steve, any comments from your perspective as trustees about the ACA and?
Just the high deductibles are so brutal, you know, I mean, and again, it's we've had a child that was on the ACA and the process. My wife said when I was leaving this morning, she says, tell the senator that he needs to sit down with somebody and go through the computer process of getting the insurance on the ACA, and it's a little more difficult. You get bounced out here and there, and it's a frustrating experience.
And it's not, it was obviously a complete disaster when it first rolled out.
We know that.
But is it, I thought it had gotten a little bit better now, and I say that as somebody who, I don't actually do it myself, my wife does it for me. But it
has gotten better, but it is still challenging.
Yeah. And my fear a little bit, I'd be anxious to your comments, and I think it was the 1332 waivers, but were some, it wasn't the 1332 waivers, but when I feel like some of these skinny plans that are being, I see particularly in certain communities, particularly down in Hampton Roads, that are being advertised, as quote-unquote Obamacare. But I think they're just outrageous, that people are paying and they got nothing in those plans.
They're insurance against catastrophe.
But they can't even afford the premium for the catastrophe.
Right.
The deductible for the catastrophe.
But and I think there's such a violation of kind of truth in advertising on them.
Yeah, I mean, as an industry, both at VHHA and here you might want to comment on the AHA, but we are very anxious about the administration's push for these skinny plans, these short duration plans, because we believe that it'll leave patients with very exorbitant medical bills, and they will not sure what they're buying, and it's going to create an adverse risk pool, which will then make the people who are in the traditional ACA compliant plans have to pay more. If you look at the results, 2019 and 20, the premiums have stabilized. Initially the premiums were rising. The last 2 years and into 2020, actually premiums are going down in 2020. There are more insurance companies writing in more counties in 2020 than there were in 19 and 18.
But if we siphon off disproportionately a healthier population into these skinny plans, just math.
At the end of the day, health insurance, healthcare probably causes more bankruptcies than virtually any other field, as many, and that's got to be addressed somehow, somehow.
Do you have? Can we? That's my old YPO days. Can we put that in the parking lot and come back to that? Because I've got some real questions I want to ask, but I think we spent a whole bunch of time on that. I want to come back to that.
Do you want to talk?
Mark, I'll just add, Mark Merrill to the senator. I appreciate your comments earlier. As a bit of a fiscal conservative, when Virginia adopted, which I thought it should have, so I appreciate your late adopter comments and initiative, and also your answer to the financial accounting that I had some concern with, and Mark Merrill knows this, that the hospital systems had to do what they had to do to get it voted for and approved in the state of Virginia. But I think the way that they had to make the state whole in the long run, if it is a long run play, really is going to, I think, impact the financial stability of the healthcare system in Virginia and put it at a disadvantage. So I would hope that that could be rectified somewhere down the road.
Yeah. But I would love to have some ideas, because I remember when I first got hired as governor, and the previous administration had been doing some things that I thought were not quite kosher.
Right.
But, you know, I know then subsequently, and we didn't do them while I was there, but then I know states, you know, we returned to some of those practices. But it is, you know, let's face it, it's game in the system.
Right.
And, you know, I just somehow making it a little bit cleaner. If anybody's got some good ideas in that area. And, you know, and frankly, we do it a little bit, but states like New York and others, it's just way off the charts. So
Yeah, we're
maybe you can put that in a clean white piece of paper without any Valley Health logo.
We'll do it.
And we're looking at, we, the Virginia Hospital Association, are looking at getting improved rates for physicians from rate enhancement. But we're anxious because the state always finds out, well, let the hospital pay for it. And the insurance company is not paying for it, pharmaceutical companies are not paying for it, nurses are not paying for it. So it always comes back to, well, let's just assess the hospitals, which we are worried that can become sort of a permanent tap into that well to do everything for in healthcare. Well, you want to talk about I think we hit the ACA. Any other comments on the ACA? Or, you want to talk briefly?
On ACA, one of the things, you know, unfortunately, I don't think anything's going to happen on it this year. But, you know, whether Mr. Trump is rehired or not, you know, we have to come back to this. So the more we can, you know, compare lists of where we think we need improvements, you know, and some of this is just overly burdensome reporting requirement. You know, I've had for years this idea: do we really need to check, you know, on a monthly basis every employee's kid's status? It's just some of the stuff is just, you know, the marginal costs that we add to and the reporting requirements. There's a bunch of slimming down on that stuff that I'd love to get your list on improvements.
I know you want to talk about the Rural Hospital Closure Relief Act.
Yes.
So these are particular questions that you'd like us to address. Are people familiar with the Rural Hospital Closure Relief Act? It's legislation that will extend the designation of critical access hospitals to an additional set of institutions which are in less populated areas but are not 25 miles away from, that are close to 25 miles to the next hospital. So we are supportive of the Rural Hospital Closure Relief Act. This hospital could potentially qualify, depending upon if there's any modification in the bed. And so we're building a new hospital, which will have 36 beds. Currently, the critical access hospital designation is limited to 25 beds and 25 miles. So, Floyd, I don't know if you wanted to comment about your perspective about how this would benefit Warren if the designation would be extended. Or Matt, I know you've looked at this at the statewide level.
Well, certainly when I was at Shenandoah for many years, so I know you know, how helpful to our community, and Page, and Travis down at Page, how helpful that critical access hospital designation is. So depending on how, you know, what happens, you know, in the final, with the final legislation, if it gets passed, it could benefit Warren tremendously. So we would certainly be supportive of it.
Good. Well, we're in the middle of, you know, in far southwest right now, trying to get Lee Hospital reopened, and it's. I think we need this federal legislation, but I'm glad to hear that you guys, you know, and if again, this is still sausage in the making.
Yes.
So, so if there are, you know, pieces that you think, you know, in the legislation that can be improved, or if there's areas that are saying, hey, you know, unintended consequence here, please let me know. This is real time.
Because there are nine hospitals in Virginia which potentially could benefit from this.
Right. So I mean, the legislation itself is really fine as it is. I mean, I think it's since 2006 there's kind of been a ban on establishing new critical access hospitals, and then you have the long list of very strict criteria that a hospital has to meet to be able to meet it, get that designation. But I mean, the legislation as is would, if passed, allow those 9 hospitals, including potentially Warren, if the leadership did the analysis and determined that it would be more advantageous to have cost status due to the at-cost reimbursement and some of the other flexibilities that you get. it could really help a lot of rural hospitals. It's, you know, you know the challenges facing rural communities throughout Virginia better than most, and healthcare is a huge issue, and this legislation is one of any number of different things that are currently on the table being talked about. A new rural emergency hospital designation, telehealth, workforce. So this definitely won't solve it by itself, but I think it's an important step that could really help some of our financially struggling hospitals.
And we think it's, it's in this basket that people are looking seriously at, but if there are, being on the committee, if there's stuff that's, that needs tweak, improvement, or particularly unintended consequence stuff, let me know.
Next, I would just briefly talk about workforce challenges.
Yes, please.
Obviously, healthcare still has a huge demand for workers. Our population is growing, our elderly population is growing, and the pipeline for approved GME slots has been constrained since 1997. Even though certain hospitals and health systems have expanded, their GME programs have private money as opposed to federal money. So the cap has been in place since 1997. Medical schools are expanding their enrollment. Obviously, UVA has expanded. Carilion has started their additional DO schools. So what's happening now is there's a pipeline shrinkage because now we've got producing more medical school graduates, but the number of residency slots have not kept up with placement. So we have more people who are trying to hassle to find residency slots. The number of applications that we have a family practice residency here. We've gone from 400 applicants to 900 applicants.
Well, over 1,000 this year.
Over 1,000 for 5 slots in family practice. And it's because the competition to get into slots, because the slots are constrained. So there has been legislation. I know the AHA has talked about, and I don't know if it's Grassley who has sponsored a bill, but to increase the number of GME slots so that we can have additional Medicare reimbursement for additional training of physicians.
Okay, yeah, I need to look more at this, because I don't think I've, because back in the old days, like 2010, 11, when I was, actually thought we might get our debt and deficit under control, the fact that neither political party has any, credibility on that issue anymore is, I thought 17 trillion in debt was a lot. Now we're up 24 trillion. It's remarkable, but it's not. God bless low interest rates. But but GME was always an area that folks were going after. I don't think I was so fully aware that that we have. Yes, I know we've increased the number of folks going into the pipeline, but you're saying if we don't increase the number of practice slots, that's interesting. So if you can get me information on that, I think
yes.
I want to just make sure my folks, Greg in my office.
You've been involved with VCUs.
Yeah, and it's a challenge. 3 years ago was the first time that the lines crossed where the number of U.S. graduates exceeded the number of available residency slots. And so there are people graduating from medical school unable to get residencies. And therefore, I will continue the training. I believe it's the state of Indiana has created a track for those individuals who work under direct supervision of a physician. It's kind of, rather than a physician's assistant, I believe they call it an assistant physician. And it's a workforce challenge that the solution is expanding the availability of training.
And that require, I don't, show my ignorance here, that actually requires, that is a federal cap on residencies?
On the funding of residencies.
Funding.
So a functional federal cap.
In 1997, when the Balanced Budget Act was approved by President Clinton, they froze the number of slots that Medicare would pay for direct education reimbursement. Now, there have been additional slots added. There's been private money or state money. Like Carilion has added additional residency slots, but they're not getting the federal match. Inova has added additional slots.
And tell me what they're doing. In Indiana, did they do a waiver?
I believe it's the state of Indiana. It's a Midwestern state that has created they realize that they're medical school graduates that can't get residency training, but they're also not able to practice on their own safely. And so there's a structure being put in place saying you have this workforce, and maybe if they work under direct supervision of a physician, they can do some of the routine care based on their medical school training. Don't quote me on the state that is, but the challenge is that individuals are going into a couple $100,000 of debt in residency, in medical school, unable to get the training that they need to be able to practice and then help the community.
So we got a system where you've increased the production at the well, and you increased the pipeline, the diameter of the pipeline halfway down, and then the pipeline diameter of the pipe goes back from 18 inches to 12 inches, so it just backs up.
Correct.
Yeah.
Correct. And versus European countries outsource medical students for residency training to other countries that don't have, they had this problem
Obviously
15,
not
20
here.
years ago. And so, no, they're basically paying them to go to other countries to do their residency training because they don't have the capacity.
And
to
how
do
much,
their
I mean, give me a ballpark on the federal reimbursement on a residency slot. How much roughly is that?
It's probably 70, 80,000 a year.
And for like 2 years, 3 years?
3-year
residency
residency
programs
programs typical.
Family practice residence, 3 years, orthopedics is 6.
Yeah. But I think the federal funding, it used to be at least the federal funding for the orthopedic, the first 3 were the federally kind of backed positions, and then after that the institutions funded them. At least way back in ancient days when I was a resident, that's how it worked.
And so certain more flush systems are simply paying what used to be the federal match?
Yes.
Or in state money.
Other
And
sources.
BCU and UVA really get state money.
And you know, since we happen to have a year this year where the coffers are a little bit full in Richmond, anybody trying to get a piece on this?
Matt, you can-
Yeah, so the state is, the last couple state budget cycles have fully funded an additional 25 residency slots entirely with state funds. The governor and VHHA recently formed a healthcare workforce advisory council to begin looking at some of these issues and figure out what we can do at the state level to try and address not just the physician resident piece, but also the nursing piece. Because, you know, when you look at the long-term projections on physician shortages, the numbers start to get pretty huge in the out years. When you look at the shortage of nurses, those numbers are already huge if you talk to a lot of folks like Mark in similar positions. And one of the biggest issues with the nurses is that unlike, you know, for a physician, you go to your medical school, you graduate, then you get a residency, then you are full doc. And as a resident, you actually can practice medicine under the supervision of a physician. For nurses, you can't actually graduate from nursing school until you go through what's referred to as a preceptorship, which is basically that residency piece for a nurse. And there's just a huge shortage of preceptors. So a lot of these nursing students will do their classroom work and then can't even do their kind of clinical rotation piece that they need to be able to graduate. So there's a lot going on at the state level around this right now. Remains to be seen what will actually come out of the General Assembly this year, but we do have this new advisory council that's starting to meet and really hammer out some ideas and solutions.
Is there a similar problem with nurse practitioners and physician assistants?
Yes. It's across the board.
Yeah, I sit on the Shenandoah University board, and we have an issue with our health sciences, and Mark Merrill would know this and everybody else. And Sharif Kaiser's not with us, who's been great as a primary care physician, as a preceptor. He precepted my daughter, she's a PA. And at Shenandoah, we're finding it more and more difficult to find preceptors with our health science graduates, NPs, PAs. It's becoming difficult.
And not to get too far down this misery, but the competition for us, for nationally an issue is that the Caribbean medical schools pay a significant amount of institutions to take their medical students, displacing local students.
Yeah.
We currently don't have that issue, but if you look in the New York area, it's rampant.
So in other words, wasn't it in Grenada or wherever, there was that medical school, and they will
Hey.
that's interesting.
Yes. And then the local school can't get the preceptorship for the PA student because they're displaced by the $50,000 a year.
And
Here's our
we can't
student,
afford
here's
to pay.
50 grand.
Yeah, Shenandoah can't afford to do that.
So that model's an issue as well.
Right.
Well, this is something I'm not that familiar with, but I'd love to learn more.
Yeah, and for rural healthcare, I mean, NPs and PAs are a huge component of our workforce because it leverages the physician to be able to expand their their practice. So
Right.
we're having 2 to 3 advanced practice clinicians under one physician supervision because I mean we have a hard time recruiting in Page and Hampshire, and Woodstock. We feel like we've got a stable cadre position now, but it's been a battle to recruit. So once we can recruit them, we can augment their physician talent with advanced practice clinicians. It expands our ability to serve that community.
I think we could get you information that would combine academia and health systems in Virginia, especially, and the issues we've discussed. I'm sure Tracy would be more than happy to work with Mark to put together that just at our local level.
And is there any kind of cool creative model that's, some federal dollars, some state dollars, some foundation dollar? Are there kind of mix and matches out there that are?
I don't know.
Yeah, are you in math?
I'm sorry, mix and matches to result in what?
What I'm just saying is if you're, if the cost of the residency is, 70 grand for a doc per year, and it's whatever preceptorship cost for a nurse and some other, whatever the interim price is for a PA and a nurse practitioner, I just wonder, is there any kind of models of creative financing here? I founded the Virginia Healthcare Foundation. Is there, for underserved areas, could I get the foundation to pony up some money along with some state? Is there anybody thinking about this stuff that's...
Yeah, I mean, we're thinking that we haven't come up with a solution. For graduate medical education, there is federal money for the approved residency slots. So the 15 slots here at Front Royal, we get federal money, both direct and indirect. But for nursing education, we do it on our own nickel because we want to create a pipeline to recruit nurses. So the schools, get tuition and they look for clinical sites. So we have clinical, rotations with our nursing university. Shenandoah is a primary, but Shepherd, James Madison, Lord Fairfax, Blue Ridge Technical. So we have nurses rotating through, but those schools don't pay us for those clinical rotations. We have adjunct faculty who will get some stipend to help shepherd the nurses through their clinical rotations, but there's not a direct payment for the institution to host as a training, to be a host for a training site.
But in terms
of Tahiri's
I'd like to get more educated on this.
If there is some funding, one of the issues for physicians, and Dr. Melvin, Dr. Nguyen, you could comment, is to take in a PA or a nurse practitioner can slow down the practice. And the physician's like, well, if I have a PA in here, it might slow me down. But if there's a way to offset some of that, so you say, okay, you might lose 1 or 2 patient visits per day, but it expands the pipeline, helping to augment their salary so that they
It's difficult because I always used to do 5 PAs a year, and this is the first year I'm not doing it because my practice is slowing down a little bit, and so it's not fair to the practitioner, and it's really hard to get the younger physicians to do it. They're just not as interested in teaching, in my experience.
Well, I would also think, is there, in communities where there's been, the conversion from for-profit to not-for-profit, and they've got these large local foundations, do they ever spend the money on this? Or like the Harvard Foundation in Martinsville? Well, give me more information.
If it were a white sheet of paper, I'd say that's an issue of concern to the Commonwealth hospitals, that there have been a number of conversions, and it's unclear if the return of those dollars are being directed as had been originally anticipated.
I know, yes.
I would echo that strongly.
I've seen that in
Fauquier being the closest one to it.
Yeah.
Can we skip down to G just quickly? We don't need to talk about this, but I'll ask Pete or Phil. These are reimbursement provisions which are very important. So Pete, do you want to address these? There's nothing at the table right now. We want these to change. We don't want to do away with all for the hospital.
None of these are in the bucket coming up in May of this year?
So whole community health, I'll let Pete talk. One thing is,
I think these fall mostly in the category of program maintenance,
Okay.
so not pending legislation. The sole community hospital status, that is a special designation to provide increased Medicare payment if you're a sole community hospital, just, and there's criteria to meet to be a sole community hospital. So we think that's legislatively strong, its intent. We'd like to see that continue. The rural health center, this is turning out for Valley Health to be critically important. In these rural areas that Mark spoke about, Woodstock, Ray, and physician recruiting, the rural healthcare center designation provides additional funding to be able to afford to attract and retain these physicians in these rural communities. So that Medicare designation, we believe, is important to maintain. Rural health center.
And they have to be HIPSA areas.
Right, there's criteria to meet
Yep.
that are summed up in the word rural. Either there's distance requirements, there's medical professional shortage areas, those sort of things. And important to maintain. Sequestration, this is pretty straightforward. That's been a slice off the top since it started. We'd like to see that reversed.
It's about 90 million per year.
Get in line, get in line.
Yeah.
But isn't that, but the truth is on sequestration, we always, for the most part, tack it on at the end of the 10-year period, so you don't really get whacked, but it's just a potential.
Well, it's about 90 million per year just for inpatient care across the state. So it's definitely not an insignificant.
But I thought
down the
we
road.
kind of got, this last budget where we kind of blew through everything, we got a little relief there.
The PPS rate this year is slightly more favorable. It's
So,
2.8.
on some of the market basket stuff is not as bad as it used to be, but it's the straight sequestration amount for hospitals. And I can't remember the outpatient number off the top of my head, but for inpatient, I believe it's still about 9 million per year.
Let me, can you note that as well?
The hospital market basket's up, but that's because the costs are up.
Right. But I thought that we kind of lost all fiscal discipline in this last round.
So, I mean, there's been further delays on the Medicaid dish cuts, and that does have a real impact today in keeping that money flowing to the hospitals. But and you're correct, it does tack on additional cuts in the out years. But that is something that is set to expire on that May 22nd deadline.
And make sure, because this whole, you need to, one of your assignments is, to make sure I have with clarity on this bucket of the May 22nd expiration things. I know you want them all, but but give me a.
I'm coming to see Greg.
Phil, can you speak to the 96-hour rule provision?
Travis, I'll defer to you.
I was on the Rural Hospital COVID Relief Act.
You trying to, don't I have a little more time? Keep going.
So this is the, I'm following this one, this is the cost can only keep patients 96 hours, average length of stay. And this is actually one that rolls up into the Rural Hospital COVID Relief Act that would take that away so that Page or Shenandoah or any other critical access hospital, if Dr. Wynn's patient needs to stay 105 hours, but you can do that. If you don't, if you continue to go over 96 hours, you're violating your conditions of participation for Medicare. So this is what
So it's relief, not provision.
yeah.
And it's compounded by the fact that orthopedics used to be the big relief valve because we do a total needed stay one day and then they go home. Well, now total joints are outpatient only, so that doesn't offset the 96 hours.
Based on the average.
It's the average patient stay.
So
I've heard something about this, but I don't know much about it, so.
I know you're.
This is not a May bucket, is this a May bucket?
This would be with the rural hospital closure.
Just
included
close
in
like
that.
that. Okay, I got it.
I know you want to talk about surprise medical bill, so before. Yeah, just take it.
Well, you guys, I mean, tell me what you guys think.
Nick, you want to hit behavioral health? You want to hit that code federal register issue?
What?
just as you're aware, the need to continue to look at updating 42 CFR to monitor reality relative to the privacy of people being treated for substance use disorder. Last time you were here, you actually were the most knowledgeable person in the room. And so, as you know, about a week or so ago, the new federal rules came out on that, and they decriminalized some of the activity around that. But the barriers to that care of that patient population, especially in an electronic health era, where you can't have the medical record seen by other people, and also from the addiction world, to believe that it more magnifies the stigma that you have your own special set of, oh, you're getting treated for that, you have your own special set of privacy requirements. It is a law that needs to be, or a code that needs to be revisited and updated to the modern reality of healthcare, which I think you were aware of last time.
Yeah, I was aware, yeah, but I don't think we've made that much progress on that.
No, we made little changes about a week ago and we celebrated that.
There's a regulation that made minor clarifications, but actually fixing the issue is going to take legislation.
Yeah.
But you got a proposal?
There's proposals floating around out there.
Talking about supplies medical billing.
So the AHA and the DHHA are both in favor of being patient out of network. And the question that becomes is how do you position the hospitals to be on equal footing with the insurance companies? We are opposed to having a payment that's mandated as 125% of Medicare, which is one of the legislation that was proposed.
Right. You're against Murray Alexander. Your forecast to be better.
Yes. But we would still, the median is better than obviously 125% of Medicare, median market rate. But we don't want to, we are anxious that insurance companies say, well, this is like a contract to you because we would end up paying what we want to. And this, we believe, should apply to out-of-network emergency and related services. But for elective services, that there should be a different provision. Because if someone elects or goes to a hospital out-of-network, the insurance company doesn't do anything. But that's really the patient's decision as to whether they have done that. But the concern that we have is tying it to 125% of Medicare. We prefer to have the arbitration provision in the language that the health system and the health plan can negotiate what the rate will be, but set a floor that would be the median or some percent above the median, so that the insurance company is motivated to contract.
Well, how do we, I have followed this, but I'm not, I'm not in the bowels of this. I am concerned about shrinkage of network so much that you got no choice. But I am, as I said at the outset, I am not sympathetic to what I think has been some of the abuse done by some of my old friends in private equity who bought up some of the emergency room practices and are frankly arbitraging a price level. So there have been a number of candid conversations that have said, I'm willing to move towards arbitration closer to the provider level, but if there was a way to draw this so that the abuses that have come from some of the PE guys, if they got the short end of the stick, I would not be unhappy. And they have managed, these PE firms with some of their ad campaigns and others have managed to build a broad bipartisan coalition, unlike virtually, there's a group of us that want to stick it to them. Because it just, I think they have been not straight shooters. And is there a way, and there have been some conversations where...
We're close to a solution at the Virginia State House.
Yeah, so I think we're, as Mark alluded to, DHHAs, we're 1,000% in support of ending surprise medical bills and getting the patients out of the middle.
Right.
We've sponsored legislation the last 2 years in the Journal. So as you remember from being when you were governor, did a single bill ever pass the Senate for in Virginia? No. And our legislation 2 years ago did, but commercial insurers had some issues with it and used their power with the state employee health plan to squash it. But I think both of you hit the nail on the head. The issue that we face here, it is egregious that you have certain doctors out there charging 3, 4, 5, 600% of Medicare, and it often reflects poorly on the hospitals when we're kind of stuck in the middle of it. But if you go the route of Murray Alexander and you allow the insurers to have this median in-network benchmark rate as a backstop, they're going to go to every hospital in Virginia where their rate is, let's say, 110% or 20 or whatever of that benchmark, and they're going to say, we're going to set your rate at 60% of that benchmark, and you're going to take it. Because I know if you don't, I'm going to still be paying you less. And that's our fear, not what these doctors and the PE-funded groups are getting paid. That's not our issue. Our issue is giving these large insurers that in some cases have 60-70% market share throughout rural Virginia even more power to dictate lower rates.
I think that there is a, even amongst Murray Alexander, I think there was a recognition that there was huge potential for use. I think there's an opening. And it's, I think we can get to a solution set here. I do think there is an interesting bipartisan coalition of people who got offended at some of the PE activity. So you guys are smarter than me. Figure out something here. But this is front and center. It's a very important issue. And again, I think we got both that the insurers and you guys are all saying let's take the patient out of the middle, which is good. But if it ends up with a solution that really whacks the whole reimbursement system, that's not good either. And you think you're at the national level, you're close. I know there's lots of folks who come to see me on this.
I think it'll be interesting to see what happens. Over on the House side, Ways and Means is supposedly, potentially today, releasing another proposal that I think is more favorable to where we want to be on the reimbursement side of things. Bobby Scott's committee on labor is supposed to be looking at this issue over the next couple of weeks as well. How it all comes together in the end, I think, remains to be seen. But I do agree with you that I think there are ways that you can narrowly tailor the proposal that gets at your concerns, but also protects hospitals. Some of that might be include looking at network adequacy requirements for insurers and some of these other pieces that have not been part of the conversation because a lot of what's been put on paper and put out there is really anti-provider, but ignores the role that the commercial insurers of the world play in this issue.
Isn't there though also just while this has been mostly going through health, it ultimately has to come back to finance since it's in the Senate stuff, isn't it?
I'm not sure in the Senate that it does have to go back through finance. I think health can go straight to the floor. But over in the House, just the way that they've written their committee jurisdictions, Ways and Means and Labor and DNC all have a piece of it. So.
Well, I know it's a problem. I've had a personal family experience with this. I've been equipped enough to realize I fought it, but I think a lot of families get hit with these bills and don't know how to, and they're getting the short end of the stick. And I do think there is a really, really interesting. This may be a case where these firms were so darn greedy for press purposes. That if they took it in the shorts, you'll get a lot of votes.
Well, that they're going to continue it.
Right, yeah.
Because the pile of money is just too big.
The pile of money. They can't help it. And again, this was not.
Something needs to get done.
This was clearly a case of a market failure because this did not exist in any meaningful way 3 to 5 years ago. So,
But they found a whole new pile of money.
Amen.
Oh boy.
Amen. And there's again, they've created a bipartisan coalition that's broader than you could possibly imagine. What else did we not hit? And I apologize, we didn't get back to.
We'll just go with you to talk here and we'll hop in
Yeah,
the car.
we can go come in.
We hit most of the items here. And here are some brief, some documents for your staff, get some background material.
Here's some reading material from the car. You know, one, thank you all. I know, particularly those of you who serve on the board, this is a labor of love. It's not something that, you know, not like the board perks.
We get hospital food.
I rest my case. But I think it really is important. It really is public service that you do this, and I am grateful for the docs. I'm grateful as well. I live part-time in King George County, east of Fredericksburg, and my best friend there is a 30-year GP, and the stuff, he's only continuing to practice because he loves the community. Just the financial pressure on a small doc at this point is just so darn unfair. And I just hope that you will continue to call on me if I'm on the committee that has jurisdictions for most of this. I still pride myself on virtually even on this subject matter. I think I'm going to say, if not every 98% of every legislation I do bipartisan, which is, I think, still the way where good policy is made. And I will promise to keep trying to do the right thing. You need to get me your top priority lists on the May stuff. I am very interested on the residency and just dealing with the nurses and the nurse practitioners. I need to get better educated there. The rural hospital closure relief act, we're going to keep working on that.
You said you want to mention prescription drug. Did you want to mention prescription drug?
Well, just prescription drug, just very quickly, is it just, as somebody, and I was a venture capitalist, so I get the idea that if you take big risks, you got to get big rewards. But it's just not fair or right that Americans pay, for all the R&D for drugs for the whole world. And I would go full on drug price negotiation. I'd even go some blended price of other first-tier industrial nations in the world. I mean, there's rational ways out of this. What we couldn't get the Finance Committee to go that far, but what we did do on the Finance Committee, you probably followed the legislation, which would basically say, can we, if a drug company increases prices beyond inflation, they have to pay the differential back to the government. Now, that's not total solution for you guys because they may be able to still stick it on the private pay side.
But the House bill is pretty good too.
But they're both. I think we're making progress in this area. One of the things that Germany does that I think is interesting is they let the drug company go ahead and set whatever initial list price they want, but then they come back a year later and do some kind of efficacy review. I mean, the fact that we don't do any kind of real evaluation of what works or doesn't work, especially in the drug field, is, I think, a mistake. One of the things that you were supposed to say thank you for at the beginning of the session. You're obviously not a well-trained lobbyist because all these lobbyists you would know better than, but just we did get in the end of the year for Corey reauthorized for 10 years, and I think we are gonna have to start doing more evaluation in terms of what works and what doesn't work. And I just don't think with an aging population, increasing technology, and all great new things that we can continue to fund everything in an unlimited way. So, thank you. They're giving me the hook. Yes, I may not have every answer, but I know how to get the photo op.
We don't need to get pictures.